All right, so we're going to start our afternoon, and so I'm going to introduce our next two speakers who are going to give us a talk. It's a great presentation called It's Going to Be a Long, Long Night, Supporting Breastfeeding on the Night Shift. And this is going to be given by Jessica's a pediatric nurse practitioner and an IBCLC in Thomasville, Georgia. She started her nursing career in Mother Baby and in the newborn nursery, and she spent 12 years as a night shift nurse and found her passion for breastfeeding in those wee hours. She currently works at the Pediatric Center, providing pediatric primary care and lactation consultants to area families, and she's passionate about increasing access to clinical lactation care in the rural regions of the state. Jessica is the current Georgia Breastfeeding Coalition president and is passionate about increasing access to clinical lactation care in rural areas of the state. She enjoys spending time with her husband and two daughters, traveling and reading. And Lauren is a registered nurse who has devoted her career to caring for women and newborns in Southwest Georgia at Archibald Memorial Hospital. Lauren spent the first part of her career on night shift, where she was able to hone her critical thinking skills and become a department leader as an experienced charge nurse. Lauren has a passion for education and is usually the first to volunteer to teach and train nurses. If you don't see Lauren at work, you'll find her at the barn with her horse, Dubs. She spends most of her days off preparing for the next bale race. And so we're excited to have them tell us about how to support breastfeeding on night shift in the long, long night. So welcome, both of you.
All right. I'm Jessica. This is Lauren. We are so excited to be here today, and thank you for having us. I feel like, talking about night shift right after lunch is a pretty good fit, since you're going to all be dozing off and getting a little bit sleepy. It might remind you of charting at 3 a.m. And so, I feel like our talk's a little bit switching gears from this morning. We're going to be really focusing on more clinical interventions and what's happening in the hospital. Hopefully give you some ideas to take back to your areas to help increase breastfeeding support in the hospital, specifically at night. As I was listening to our morning presentations, I really appreciated the talk about the upstream interventions and trying to get there versus just pulling them out of the river. And I felt like that's really what breastfeeding is. And so, as Dr. Warren mentioned, this starts before the OB ever sees the patients, as far as our maternal health. And it starts really all the way back at the beginning. It starts really all the way back at breastfeeding. And what better way to promote health, prevent obesity, than make sure that our babies are getting the best start and the best nutrition. So we're going to go ahead and just, I think that works. So some quick introductions. You can see my family on the right. I've got two little girls, and then you can see Lauren can introduce her family on the other side.
So my family is a 1,200-pound animal. She's beautiful. Oftentimes people ask me, well, why'd you name her Dubs? Do you win a lot? I said, no, the only thing I could win is her heart with a handful of cookies. But that's what I do on my days off, and I love doing it.
And we have no conflicts of interest to disclose to you today. So these are our objectives. You can all read them. We're not going to read them to you, but we basically want you to think about what are the challenges on night shift, what are some things that we can do to help moms be more successful, and support our nurses and our staff on night shift.
So oftentimes it does feel like breastfeeding initiatives do fall apart on night shift, and there are several things that we can put into blame for this. As a nurse who's been on both sides, I was a night shift nurse for 5 years, so I feel like I have treaded that territory in what can go wrong. As a nurse, 5 years being on there, it felt like night shift and day shift were two quarreling siblings, and oftentimes we would run to the mom, the nurse manager, to tell her, our part. So there are some things that we put up here that often could be heard or said. Mom said she was scared that the baby was losing too much weight, and the night shift nurse said she needed a supplement, so the pediatrician would let them go home the next day. The mom of the baby in the NICU with the baby in the NICU pumped, didn't pump all last night. So we all know that if she's not pumping, somehow that baby's not getting her milk.
And it seems like we're always kind of blaming day shift is blaming night shift. Night shift feels unheard. And so we are just going to address some of the things that we can do to help bridge that gap and to provide the best care for our patients. So why does this really matter? We know that it's not just the perception that breastfeeding kind of falls apart at night. We know that it actually does. We know that formula supplementation does increase at night. Research shows us that infants born at night have double the odds of receiving in-hospital formula supplementation. We also know from research that that supplementation that's not medically indicated increases during the nighttime hours and within the first 24 hours after birth. And there are certain groups of moms and babies that are more at risk. First-time mothers, babies born to moms from a C-section delivery, mothers who have no previous breastfeeding experience, female babies, and LGA babies are more likely to be supplemented at night than other babies. Lauren and I both have commented on the female babies and what that kind of means. I didn't see any reasoning and research about this, but would love to hear some opinions about it. One thought we had is a lot of times we notice from our own practice that our baby boys are often a little sleepier, a little less likely to be as active in the first day or two, and sometimes our girls are a little more demanding, so maybe that's part of it. So why is formula supplementation a big deal? It's a big deal because we know that introducing formula, even in small amounts in the hospital, is associated with a decrease in breastfeeding exclusivity, I can never say this word, exclusivity, and early cessation of breastfeeding. And so even when we do a little bit of formula and they're pretty much going home breastfeeding, we know it's going to decrease the risk of still being breastfeeding in a couple of months. One study shows that infants of moms who intended to breastfeed that received formula in the hospital correlated with a 2-fold greater risk of not being exclusively breastfeeding at 1 and 2 months of age, and a 3-fold risk of stopping breastfeeding altogether by 2 months. One thing I found interesting in this study was that the increased risk of stopping breastfeeding was significant even after adjusting for the strength of the mom's feeding intentions. Sometimes our perceptions of how committed a family is to breastfeeding can alter the education or assistance that they receive with breastfeeding in the hospital. And I found it interesting that this study showed that even moms who really had a strong intention to breastfeed still had that same risk of stopping in the first 3 months if they received formula in the hospital. We also know that early and frequent breast stimulation is important for milk supply. Supplementing often decreases that frequency of breastfeeding during that period of time. That's really crucial and can lead to a decreased supply longer term for moms. And we also know that one of the biggest reasons moms stop breastfeeding is perceived low milk supply. And then the last thing about why does it matter is a study showed in 2019 that introducing cow's milk in the first 3 days increased the risk of a diagnosis of cow's milk protein allergy at 2 years of age as well. So our goal is to get our babies first to get breast milk as their first feeding of their life, but we also want them to be getting breast milk and only breast milk, hopefully until 6 months. And so we want to get them out of the hospital getting only breast milk. And so a lot of times, night shift is where everything seems to get a little bit hairy. Oh, sorry. So why does everything fall apart at night? One study looked at those reasonings and came up with 3 different themes, and you probably can identify with these themes in your own practice, in your own hospitals. One of the themes is competing priorities. So this theme is seen in both the family's priorities and the nursing and the healthcare provider's priorities. As we talked about this morning, we've got moms with lots of comorbidities, lots of extra social things, mental health things going on, And so we've got a lot of different priorities that, that the mom is handling. They're also handling visitors and other family members. And then we've also got the nursing staff and the frontline staff who are trying to balance all those different priorities for mom as well. And so that's a big thing on night shift, where everybody's tired and we have less people around. Our second theme is incongruent expectations. A lot of times our parent expectations of newborn behavior and feeding might not line up with the reality of newborn sleep and feeding patterns. And then we have institutional structures such as hospital feeding practices, our policies, our staffing that affect breastfeeding support. So Lauren's going to discuss some of those related barriers next.
All right, so night shift, also called the skeleton crew. I've looked up some definitions of that, and you think, skeleton crew. It basically is what can we do with the least amount of staff and keep things operable. Emergencies still happen at night. Breastfeeding still happens at night. So night shift staffing is less robust than day shift staffing. We don't have support on night shift that day shift would have. There's not dedicated lactation consultants on night shift. We don't have one personally for every 24 hours, and few hospitals actually have 24-hour lactation consultants. We have less manager presence and less flex staffing during these busy times or emergencies that can happen. Night shift staffing is often comprised of less experienced nurses, and they may lack education regarding breastfeeding. I know personally when I was on night shift and I had a question, Jessica wasn't there to rescue me. I had to figure it out all of my own. Lactation education is often less learned in nursing school because it's such a short time period when we do go over that topic. So less nurses were doing the same work and less experience. All right, and competing priorities for staff. So staff struggle with balancing care for patients' needs, and providing breastfeeding support, which may take extended amounts of time. So why and what can we do to help this? When assigning patients as the charge nurse, when assigning patients, we really want to keep the acuity of these patients to make it prioritized. And sometimes we may have a fresh C-section, but also have a mom who's really having trouble breastfeeding. And we all know that sometimes going in a room and helping somebody breastfeed may take an hour, but we also have this fresh post-op patient who's also a priority. They have also been reported differences in night shift attitudes compared to day shift attitudes regarding breastfeeding. Oftentimes it feels because night shift still has to do the same work that day shift is doing, but there's less people. Night shift reported to be less committed to providing breastfeeding support because of the perception that benefits of rest outweigh benefits of providing breastfeeding support. So personally, there's several times I had this experience with new moms, and they would often exhibit signs of anxiety. They would have high heart rate, they would have shortness of breath, and they'd be dizzy. And I'm like, would check everything and go through all my boxes, and I would say, I really think you might just need a rest. But I still kept her and her breastfeeding journey at the top of my list, and so I let her rest, but I still made sure that she was up, looking after her baby, looking at those feeding cues, and even offered the chance of donor breast milk. Okay, so things that also night shift nurses are having to work with. Funny story is this picture makes me think of my grandma. I always used to have a tendency falling asleep on the way home from work, and she said, Lauren, if you just roll your hair up in the window, then you can't fall asleep. And oftentimes, I was in my 20s when I was on night shift, and I felt terrible, like a walking zombie most times after work. But night shift work can have physical effects on the body, such as diabetes, obesity, and even one study shows that heart attacks are increased by 40% in some of the night shift workers. Depression, divorce rates, and even injuries, because at night, you're not focusing, you're not paying attention. So I also mentioned too that there could be a needle stick injuries that are possible.
So not only do we have staff barriers at night, and if you've, most of you are you know about staff barriers at night if you are a nurse manager or worked in the hospital. But we also have different patient barriers as well. And so night shift is often the times when when everything kind of hits them. So I loved working night shift because I love the more intimate one-on-one experience with my patients. I felt like there's lots going on during day shift, and then night shift, everything calmed down a little bit, but it was often when our moms were the most vulnerable. It's when they needed the most help, and it's when they feel like everything seems to be kind of slipping through their fingers. And so we know that for our parent barriers, maternal medical needs is a big barrier. We talked about all the different morbidities and the hypertension, the postpartum hemorrhage, all those things. Our moms have a lot of comorbidities, and so they need that rest. There's maternal exhaustion. A lot of times there could be limited support at night, so not only is there less people around for staff during the night shift, there's often less visitors and support system around for moms. As we were talking about some of the barriers for getting care and the lack of child care for the other children, especially moms who have multiple children, their support person family might be going home to take care of those children at night, and it might just be that fresh C-section mom by herself. And so there's limited support there. We also have a lack of prenatal education regarding breastfeeding initiation, feeding, and nighttime sleep for our moms. Often moms do not have as much prenatal education about what to expect after our baby is born. And so our Western culture expects long stretches of sleep at an early age. We all know that that's not typically what our newborns do. And so they want to feed frequently, they want to be awake, they're usually awake at night more. And so that incongruence can really cause a lot of stress for parents and a lot of fear that they're doing something wrong. So now we're gonna move into talking through some scenarios. So all these scenarios are things that we see frequently at night in a mother-baby unit, and talk through what are some things that we can put into place to help provide better support at night, both system changes and policy changes and education. So our first scenario is about Sarah. And Lauren's going to give the scenario, but I'll let you know that this is my first baby right there. So that's Brennan, and she's 14 now, so 14 years ago. And when I put up the slide, one thing, we were talking about celebrating our successes, and we've got a long ways to go. But 14 years ago, I was a C-section. Back 14 years ago in our hospital, when you had a C-section, your baby went to the nursery. It stayed in the nursery for those first 3 hours of vital signs. I did not see her. I did not breastfeed. I did not, anything until after about 4 to 5 hours, because of course I had some high blood pressure and they're trying to figure out if they're putting me on MAG, and they wouldn't let me go over. And so I had a waiting room full of people that were very excited to see her. And so Lauren's going to talk about, the difficulties in this scenario of balancing visitors and the excitement around a baby and the mom's exhaustion.
All right, so we have scenario 1 of Sarah. Sarah is a G1P1 vaginal delivery after a long labor and a difficult delivery. Being the first grandchild on both sides of a new family, they obviously had a lot of visitors in the waiting room, and they were waiting throughout the day in and out of the room. Baby was often swaddled and passed between family members. Mom attempted breastfeeding several times, but Sarah was uncomfortable feeding in front of her visitors, and baby was sleepy. When night shift came in, it had been over 6 hours since that last breastfeeding, and Sarah was exhausted and stressed that the baby had not eaten. On admission, Mom had stated she planned to do both. So the nurse offered to take the baby to the nursery and give a bottle so that they could rest. Dad was very concerned for Sarah's exhaustion and readily agreed.
All right, so we know that what happens on day shift affects night shift. I'm just going to add, I forgot to add, so now in our hospital, if I had delivered not 14 years ago, I would have gotten to see my baby immediately, and I could have done skin to skin in the C-section room, and I would have had them in recovery. And so that's a win for us. So when we're talking about night shift and day shift, night shift and day shift do not exist in a vacuum. So whatever happens on day shift is going to affect night shift, and whatever happens on night shift will affect day shifts. We know that during the day, one of the biggest things that can affect breastfeeding, especially with frequent visitors, is the amount of people that are coming in and out of the room, both their visitors, which we want our families to be able to come and we want our families to be there, but also all the people that we bring with us. It's often that I'm helping a mom breastfeed in the mornings before I go to clinic, and I have at least 4 to 5 hospital workers interrupt during that 30-minute time. Dietaries coming in. We've got our OB coming in to check them. We have nurse managers coming to round in them. And so many interruptions during the day can really affect mom's ability to nurse, to feed, but also for them to get rest. One of the things that we can do is to implement specific rest time during the day. How many hospitals have a rest quiet time? So a couple. This was something that our hospital did pre-COVID, and we made lots of changes pre-COVID, and it's something that during COVID, it just wasn't necessary, right? Because everything kind of shut down during COVID. I always say one of my favorite things about COVID, maybe my only favorite thing about COVID, was the lack of visitors in the hospital, because before, you felt like you were really fighting to help that mom get some rest. And then I remember thinking during COVID, I haven't had a mom cry on me recently. Like, it used to be almost every single day that you've got a mom that was just exhausted and crying. And during COVID, it was like, wow, like nobody's crying anymore, which was great. And then now we're post-COVID, and everything just kind of trickled back in, and some of the things that we implemented before we're not doing anymore. It just kind of got dropped. And so thinking about how can we make sure that these moms are getting rest and having a specific quiet time has been shown to, one, increase maternal satisfaction, and everybody knows we got to get our satisfaction scores where they want them to be, so that's a win for the hospital. But it also increases our breastfeeding rates because they get an opportunity to breastfeed and to rest during the day, but then they're not so exhausted during the nighttime. And so that's one thing that you can do at your hospital, implement a rest time. It's something that's done other places, so it's not exactly just maternal. They do this in the ICU and other high-risk places where patients need to rest. And then Lauren's going to talk about rooming in, which is, I know that we're going to talk later in the conference. There's some more discussion about rooming in, so we won't spend a ton of time about it.
So infants kept separate in the newborn nursery have been noted to receive significantly more breast milk substitutes and significantly less breast milk than babies who room in with their mothers. I feel like one of the points is this because mom cannot put the baby to the breast because he or her is not with them. Keeping mother and baby together can also increase confidence to be protective, stress against related changes in parenting roles for some mothers. Breastfeeding increased maternal sleep duration in the first 48 hours, and perceived nursing attitudes towards rooming in plays in a role in maternal desire to room in. So oftentimes that I feel like I see is I have moms who have older moms. They're like, they come in like, there ain't no nursery anymore. What are y'all doing? Where's the babies at? Can I see them? I said, no, the baby stays in here with you at all times. So oftentimes it's not only the patients and the nurses that rooming in can be perceived as good or wrong, it's the fact that their family also plays into this part. Okay, strategies to improve rooming in. So I'm just going to hit several notes here, and these are some scripts that we can do or say to our patients. No one will take your baby out of the room. It is your baby. We are here to help and provide appropriate teaching to this patient. So I like to tell my moms what to expect when they're rooming in with their babies, and tell them to look for feeding cues oftentimes and hold your baby. And listen to your baby when it's hungry and it's showing those feeding cues. Also assessing sleep, cluster those activities that Jessica talked about, and infant safety. So nursery on wheels, we actually have at our hospital, we go around and weigh all the babies, and we have all of our supplies in that room with the cart. That way we're not interrupting it as much as possible. This also stands out to me because most moms try to do it on their own. When I talk about we're here to help, oftentimes my new moms, they want to be the perfect mom and not ask for help and think that they can do everything on their own, and they can't. This is a new journey, and I'm here to help teach you. And especially if they don't ask me for help, I'm just assuming that they may be okay. And what if it's busy and I don't get to them, and then this affects their outcome of their breastfeeding journey?
All right, so the next thing we're going to talk about is a new baby named Mary. Let me find Mary on here. Mom's name is Mary. So this mom, Mary, just had her second baby. She really wants to breastfeed because the last time our baby went to the NICU, she wasn't successful in breastfeeding. Our baby's now 30 hours old. It's the second night, and our infant's very fussy. Mary calls our nurse to the room because when she breastfeeds her baby, she'll stay latched for a few minutes and then goes to sleep, and when she goes and puts her back in the crib, she cries again. She attempts to put her back to the breast, and then she falls asleep again, and Mary's really worried that her baby is hungry and that she is not getting enough to eat. And says, I don't mind supplementing because you had to give formula last time. And so we are going to talk a little bit about having a supplementing policy. So I want to be real clear that I'm not against supplementing babies who need it, and I don't think any of us are. We know that there are a lot of babies that might need supplementing for medical reasons, and then there's some times that we need to supplement because of maternal requests or exhaustion, and so we're going to definitely have times that we need to supplement. My biggest pet peeve is when a family calls and asks for a bottle and they just get brought a 6-pack of bottles, put in the crib, and that's end of discussion. This is especially true for patients who put that they want to do both when they come into the hospital. We're going to talk a little bit in a minute about love counseling and how do we kind of make sure that we are asking the right questions and really listening and hearing our parents and our moms. But for a lot of times when our nurses see both, they are very quick to assume if they ask for a bottle, that's it. We're done, right? And so that can affect what kind of help our moms get and what kind of education that they get. And so having a supplementing policy is a strategy to make sure that each patient is getting the correct education and they're getting appropriate amounts supplementing, and they're offered different ways to supplement. And so this is from the Academy of Breastfeeding Medicine. They've got a great protocol about supplementing. And so some of the things that you want to do is you want to make sure that you've got a hospital policy, and they suggest that it requires a medical provider order for medical and necessary supplementing and informed consent from the mother when it's not medically indicated. We want to make sure we're educating on the risk and benefits to our patients. So a lot of times I feel like that's the piece that we miss. Nurses and providers are nervous to offend. And so when they're asked for a bottle, they feel like just giving it to them, giving what they want, they're not offending them. And then a lot of times I find that especially our newer providers, nurses, they don't have the language and they're not confident really to have the discussion with the mom. And so instead of engaging and asking more questions and educating, they just want to make them happy. And then a lot of times what happens is they give them a bottle. Baby sucks down 2 ounces and the really fast flow, and then it confirms that parent's fear that their baby was starving. And so when we supplement in a more appropriate manner, we can help make sure that we are supporting that parent's journey. And so the other things that we want to do other than educating is that we want to make sure that we are trying to offer the right supplement. So ideally, we want to give mom's own breast milk. If we can get our nurses helping to hand express and get mom's breast milk through hand expression, that is ideal. Next is donor milk, and donor milk is something that we've had at our hospital for 3 or 4 years now, and is a great option. And we're not a NICU, so we have donor milk, and we're just a regular nursery. But it is a really great option for when we need to medically supplement, or moms just need a little bit because of anxiety or exhaustion. And then last is formula. And then we want to make sure that those supplementing feeds are cc's amounts. A day one baby is not going to usually take 60 cc's. And so we want to do those smaller amounts. And then we want to offer it in a alternate method when possible. All right.
So another solution would to be,
Sorry.
okay,
So I'll take this one. I missed this slide in our thing. There we go. So another thing is we want to make sure we're educating the family about normal newborn behavior. And this should not be left up to night shift. This should be going the entire stay. Because when you get to night shift and you've got a baby who's really fussy and you don't know that to expect that they're going to feed more frequently at night, that parent thinks they've done something terribly wrong and everything's going bad. If they know that this baby is going to be super fussy that second night because they want to be held a lot, they're going to want a lot of attention, they're going to feed more frequently because that's expected newborn behavior for us. I love to tell my moms that we're going to have an all-night buffet tonight and expect it. And usually when I come in the next morning, they tell me, we had an all-night buffet. But when you expect it, it's much easier to handle than when you have no idea. And so some of the things that we can do is we can provide them education throughout the stay. These are a couple of the different education resources that we have in some of our materials, but gives kind of that first 3 days of life what to expect. And this was from some Georgia 5-star materials that were given to us several years ago. And then Q's Not Clocks is another thing that we use at our hospital to help remind them that we're feeding on Q, not by clocks. And that helps our new parents understand what that behavior is. And then I mentioned love counseling earlier. So love counseling is another thing that I learned from Georgia 5-star that I loved counseling. But when we talk about really understanding what our parents are worried about, that is going to, we heard the lived experiences and we heard that they didn't hear heard. And so we want to make sure that our parents feel heard. And so love counseling is really great at helping us have a structure for that, because we want to listen, and a lot of times we listen, but then we jump to education. We want to next ask an open-ended question. So if our patient calls for a bottle in the middle of the night, we want to say, tell me why you feel like your baby needs a bottle. versus just handing it to them or jumping to tell them why they don't need a bottle. A lot of times, open-ended questions, I learn lots of things. Sometimes I learned that mom had a breast reduction 3 years ago that wasn't documented anywhere, or she has a lot of risk factors where she might really need a medical supplement for that baby. But when we ask open-ended questions, we get a lot more information. And then the third thing with love counseling is validating. So when we validate, it means that we hear them. And we can't educate where they're going to hear us and understand until we validate. And so validating is a super important part, and it's a part that we want to jump because we want to give them all the stuff we know. And we want to give them all the good stuff, but they're not going to hear anything unless we're addressing their specific concern. And then we're validating that, yes, we hear that you want your baby to be fed. That this is a very common thing. Lots of moms feel this, and validate that experience for them. And then the third thing, then we can educate. And once we know what the concern is, then we can specifically educate. And it may be completely different than what we thought we were walking into the room to tell the mom. We only got a couple minutes, so we got to speed through this next one. So then our last scenario.
Okay. Lindsay delivered a baby at 2120, a V C-section after a failed induction. Baby went skin to skin and was rooting in the recovery room, but baby was unable to latch. When the new nurse, Molly, receives the couplet on mother-baby unit, she attempts to help the baby latch, but she notices that Lindsay's nipples are flat and breasts appear swollen. She has trouble helping the baby latch. The baby's quickly frustrated. The nurses are also newer that are on the shift with her, and they lack experience and are way too busy to help. Molly tries a nipple shield, but Molly's unsure how to help and how to help the mom use the nipple shield. Molly is also receiving a new admission and can no longer spend time helping her latch. She tells Lindsay to keep trying and that the lactation will see her in the morning. When the pediatrician comes in the morning, he's upset that this baby's gone all night without feeding.
So what are two more things that we can do? Go ahead, Lauren.
Increase in lactation expertise through breastfeeding champions. So multi-targeted education efforts, including orientation programs, role modeling, mentorship, and role playing. And to me, when I read this statement, it's almost like playing house. You know, we do it when we're little because we want to be perfect when we're later on in life. Providing opportunities to shadow lactation consultants. And then breastfeeding champions on night shift provide role models that support the development of breastfeeding knowledge and skills. So someone to help them feel like they're actually not doing something wrong is one of the things. Is when I was on night shift, a lot of times I felt like I was doing something wrong. I didn't have Jessica's guidance or experience there, and I was like, well, what if I'm telling her something? What if I'm telling this new mom wrong information? So I felt compelled that I wasn't even good enough for her.
So we want to focus on building confidence in the night shift nurses so that they feel confident in providing education. You and I know that the amount of lactation education that you get in your medical program or your nursing program is very, very little. And so most of these skills are learned on the job. And so GAP-QC, the Optimizing Newborn Nutrition Initiative, is an excellent way to give your nurses a lot of resources and support. They have really created really short lessons because nobody's going to have time for anything long, and targeted lessons so we can help support that. And nursing leaders play a big role in setting the tone for your unit and for promoting that education. So I know a lot of the people that are here in a hospital role, a nursing role, are managers, and you might not be in direct patient care, but your leadership makes a huge difference in your hospital's success with those initiatives and education. And the last thing is an important thing. We know that the more staffing we have at night, the better outcomes we have. And so there's a study done that nurse-reported compliance with A1 staffing guidelines was a significant predictor for breastfeeding rates in hospitals. And so when we are meeting those A1 guidelines and we have good staffing, it means we have some time to do the breastfeeding part. Because a lot of times that's going to drop off because it is more important for this mom to live than to breastfeed. And so if we're going to choose our mom living or our mom breastfeeding, we're going to choose our mom living, which is appropriate. But we want to make sure that we have enough staff that we can do all the things for the mom. And then the other thing is we also know that when you have dedicated lactation consultants in the hospital, it increases our rates. And as Lauren said, most of the time, if you are lucky enough to have dedicated lactation in the hospital, they're not on night shift, they're on day shift. And we know that night shifts where it might fall apart, and so increasing lactation presence at night shift is a big thing. And I feel like that's a policy thing, because hospitals aren't going to do it unless they are getting a financial incentive to provide that support. And so all our policymakers in the room, I want to put the push for getting lactation support into our hospitals. So that is the end. And we thank y'all so much for having us.